Yeah, thank you, Stefan. It's pleasure being here and also working with you. It has been quite some time, and just for my disclosures, as Stefan mentioned, I'm a couple of disclosures, but mainly for this talk relevant. I'm co-founder of GME, German Medical Engineering. And it's really like a lot of fun also to work with you, because with all this, just to say I have different hats on. So my main role is I have my own translational research laboratory at Mass General Hospital, where we do the more basic research, but then it's also fun to work with one or two startup companies. Actually, it's the other one is Blossom Innovations, and it's really like great to have discussions and give some advice. And coming up as a result of these discussions with some really new treatment algorithms. And one of those is the FlexSys. But one thing I just wanted to say: don't be fooled by the small size. It's actually you may know this big closets and room-filling devices, ruby laser and hair removal lasers, a copper vapor laser, which is a 578 laser, which was actually a very good device. But one of the reasons why you pretty much don't see it anymore, you had to hire a technician, and you had to build an extra room to have the supply unit for the laser. So just like to use this opportunity also, not just talk about this device, I wanted to share with you also briefly a couple of slides, just the big picture, basically, a little bit of laser history. And I think since the laser was invented, basically, as early like in this book of 1971, clinicians always tried to use it for many things, to remove port wine stains, to remove tattoos and hairs. And some of that worked pretty well, and sometimes early on specifically, you cause a lot of scarring also. And but it's always the same. You wanted to, whatever you didn't like, you wanted to destroy, basically, remove unwanted hair, unwanted pigmented lesions, unwanted vessels. It's just selectively destroying it. And really, like, one of the groundbreaking theories behind that was published by my mentor, Rock Sanderson, together with John Paris in 1983, Selective Photothermolysis. Basically, he taught us all how to use a laser to selectively and not just burn off unwanted targets. So basically, in essence, what it says, you have to select the right wavelength to, depending which chromophore you have to choose, and match the pulse duration to the diameter of the target, and then go as high as you can in order to have good effects on the targets. And that since 1983 was some of the gold standards in laser therapy. So that's basically how it works. You have a deep-lying target, like a vessel, you apply some pulse, and because selectively absorbed, you heat the vessels. And here with pulse dye lasers, that was for many years the gold standard for treatment, for example, of port wine stains. You see the purpura, basically selective damaging through the skin of the vessels, and the vessel disappeared. And also with, you can use also selective photothermolysis to have epidermal pigment removed, Q-switch pigment absorbed wavelength, but also IPL, filtered IPL, were many times used to do these lesions. However, there's one problem. When you use an IPL and try a large spot size to selectively remove the pigment, well, if you have light skin and really dark one, it's easy, basically. But if you have a low contrast lesion, so like just a little bit of more pigment or darker skin, it's difficult to get the threshold exactly right with selective photothermolysis sometimes. And if you're above and have a large spot size, then you have a problem. And because you can have these footprints, hypopigmentation, and PIH, in worst case, even scarring. So there are some challenges with selective photothermolysis sometimes also. And another problem with these kind of treatments is also when you use, for example, this is an example which I experienced myself, basically, with an IPL. You treat this one patient, and you see it's barely visible, just a slight gradient of pigmentation. And when you treat with an IPL, with every pulse you see here, was the same setting. But if you measure the pigmentation, it's just less than 10% different between the lower part and the higher part of the leg. But you have a very sharp threshold, and all of a sudden, if it's just a little bit above, you get this, this really like dramatic and unwanted side effects. So it's just a little bit of a teaser. Well, if you have large spot size, that's a problem. Well, if you would do this in a fractionated way, that may be different. So let me just show you a few more. So this is one of, so I had the pleasure also to work with rocks at the Verman. And now, 20 years ago, actually, it was 2004, we published the first and conceived and fractional photothermolysis. And basically, at that time, everybody tried to make homogeneous exposures, but we tried to do the opposite, really, really small spots, basically. And we called it fractional photothermolysis. And it became actually very popular. Initially, it was just, we wanted to use it for photoaging and having fast recovery. But it's used for many things, and new indications, like we also will later hear today, are still after 20 years being established, and new modification of fractional are becoming used. So even after 20 years, fractional photothermolysis, which we've introduced 20 years ago, is still a very hot topic. It's established, but still hot and emerging at the same time, which I found quite surprising after 20 years. So we know that the size really matters. If you do a large injury, you get scarring. If you do a small spot, even you also completely cook and fry it in a small area, it heals very nice and you get repair. So the indications typically with classical fractional applications, where you use a water-absorbed wavelength, so no selective photothermolysis, water-absorbed, infrared-absorbed, you get something like normalization. So initially it was used for treatment of collagen, hypertrophic scarring, you do a fractional treatment, it gets less. Atrophic scarring, you do a treatment, you stimulate collagen, it gets up, basically you get more. It's somehow actually magical, the self-regulating effects of fractional photothermolysis. And pigmentation, you can remove pigment, even if it's not a pigment-selective wavelength. And you can also stimulate. And later on we'll see some images also where fractional treatment in combination with something facilitate the repigmentation of vitiligo, basically, also. Vascularity, typically, it's done with selective photothermolysis, that's the goal. But if you use fractional treatments, water-absorbed wavelengths with quite high energies, you can do also point welding, but just some, so on the right side, it was with fractional with high energies it was done. Anyway, the point I wanted to make, fractional is, after 20 years, still very popular. You can treat collagen, you can treat pigment, and you can treat blood vessels with fractional that was known. But you can probably do it even better also, because what I'm showing you here are only using water-absorbed wavelength. That's how we started, because it was water-absorbed wavelength to make, independent of pigmentation, these kind of small microscopic thermal damage zones. But so far, really, nobody has combined selective and fractional photothermolysis. So it's either you use a large spot, typically selectively absorbed laser, or you have a small, focused, water-absorbed spot. But the idea of combining both, basic selective absorption with a small spot, is in some way, I would say it's a little bit not the typical paradigm, basically, but it makes quite a bit of sense, as you will see, for certain indications. So what is a FlexSys? Just very briefly, it's a flexible laser system where you can simultaneously have two different complete modules, and you can combine them as much as I know as you like, but up to two in one device. So my favorite, but it depends on the patient population. So I like the combination of a fractional laser, then you can do the 1550. Then you can do with that all what we know with classical fractional laser treatments. It's very similar. It's all the indication of classical fractional laser treatments, but also I think today I'd like to bring your attention to the 577 nanometer, which is a yellow laser, which is a diode laser, very low in maintenance, very small but still quite powerful, and will allow selective treatment also of vessels and opens up additional indications. Here are the technical specs. The 1515 nanometer, the typical fractional laser, but the 577 on the right side is used in a fractional matter, basically. So the spot size, so I'd like to, not sure if I can, do you have a pointer here?
Works this way.
Ah, okay. So you have to point to the screen, not to the... you see the spot size, and there are two, you can have either a scanning device attached, and it's 0.7 millimeters, so 700 micrometer, or you have just a pointing handpiece, it's 1 millimeter, basically. And that gives you quite high fluences, basically. So we're talking from fluences within the individual spot of 4 to up to 100 joule per square centimeter. Typically, we use like 20 to 30 joules per square centimeter, which is the fluence within each MTZ, basically. So if you compare that with typical pulse dilator treatment, it's quite high, basically. And you would never do that with a large spot size, but because it's small, even if you would be above the damage threshold, it still heals nice and quickly as a fractional laser. So here, a few slides about the 1515 as a classical non-ablative laser. It can be combined with a cooling unit. Then you have better, which has some advantages also. And as we know, cooling can reduce, can enhance comfort. And these are the classical non-ablative fractional laser indications. Just some examples here. But there is 10% coverage and 40 millijoule in this example here was used clinically. And you see, like we all know, with fractional lasers, very good remodeling of scars, basically. And that's with a 1550 nanometer handpiece. So nothing completely innovative, because it's part of the fractional concept, but it's good to have a very powerful fractional laser built in as one of the 4 options that comes with the device, basically. So you don't have to get a really expensive standalone fractional non-ablative unit. It's already part of the system, basically. But then you can add the 577 and the vascular indications. It's the yellow laser 577. And there you can also treat vascular lesions and also pigmented lesions. And let me explain how you can do both at the same time, but I wanted to focus on the vascular lesions. You see the spot size is 0.7 millimeter and 1 millimeter. And it comes with the 2 handpieces, the pointing handpiece and the scanning handpiece also. So if you look to the absorption band, you will notice that you have the classical pulse dye laser at 585. That's the orange band. And you see that for 577, which is a yellow one, there is a maximum absorption at the oxyhemoglobin for basically capillaries and fine red blood vessels. It gives you the absolute highest absorption. And it's really like down to a couple of nanometers, basically, really the peak absorption for oxygenated hemoglobin. And if you consider that the absorption of melanin is relatively flat, it gives you the really, you can say it's the most selective wavelength for treatment of oxygenated blood, basically. So we then basically, and Dr. Caesar will also show you more clinical pictures. I'd just like to explain you the concept. So instead of using a large spot, only 30% with a small 0.7 millimeter handpiece is treated, and we can have much higher fluences. But interestingly, it's probably also like point welding. Even you treat not the entire area, you have a homogeneous improvement of the vessels, basically. What I wanted to mention also, and this from another paper we have published, when you do this, it's important not to compress the blood vessels. So this is another publication where we've used OCT imaging to see how the vascularity changes if you compress it, basically. If you compress the skin. So you will, this is with OCT, vascular OCT, you see that within the papillary dermis, the vessels, no compression. If you compress it, there are no blood vessels, meaning no chromophore. And interesting, if you let go then the blood vessels coming back, sometimes even more than before. So if you compress and let go, then you have more blood vessels, or if you cause any kind of other stimulation. What that means is you should not combine vascular treatment with contact cooling, because then you have compression, basically. And when you compress, no good effects on specifically the fine blood vessels. And basically, that's also a way how you can, and also a similar effect has also cooling. While cooling is good to reduce some discomfort, but if you have cooling, the blood vessels can also contract, basically. And we will later on see some techniques that cooling is really not necessary and even has some advantages not to cool if you go for vascular lesions with a fractional laser, basically. Here are some examples. So it's specifically the very fine superficial vessels, and which are very nicely responding to the 577 yellow laser. And remember also, you could say you could do it also with a pulse dye laser. Well, then you have the purpura. There is no purpura when you do this. There is no scabbing. It's just a very smooth reduction of the redness of the superficial vessels. And also what is somehow difficult to treat, just some very diffuse erythema. And again, we see much more clinical images, just like to, for illustration purposes, show you the effects of the 577 highly selective yellow laser. And there is also, if you, because you have it in the same device, you can combine the 1515 regular fractional laser with the vascular selective fractional laser, then you get even more marked effects. But I don't want to take the clinical pictures away. They will be presented after me. So really, like in this device, you have two complete fractional treatment modalities. One with a water-absorbed wavelength, 1550, which is equivalent to the regular high-end fractional typical remodeling laser, but also in addition, you have the opportunity to do a 577 vascular selective vascular fractional treatment, and that's quite unique. And think also what it could mean, for example, because we all know, and sometimes we are torn apart, basically, if you have early scars, the pulse dye laser is really an excellent tool when it's still red for an early scar to treat. And then later on, a fractional laser to enhance the scar remodeling. But now we have both, the best of both worlds, so you don't have to decide, do you use a pulse dye laser, do I do? You can treat both, and you can really get excellent results on an early scar that pretty much completely resolved. So it's really like, and even if you have a small device, both are included. And now, this I wanted to show you also what the disadvantage of a large spot size is, because I showed you this picture before. If you have a large spot size, if you're above the threshold of selectivity, you get these catastrophic side effects, which take a lot of time. On the right side, and this is really, really very high energy, on the FlexSys device, you see this little dotted area. That's not what you typically see. You see this here? This is little sprinkles. This is epidermal crusting with really like high 577 energy, way more as you typically get. So you don't typically get this crusting. But I wanted to show you to that even you get this heals nicely. While on the left side, boy, and everybody who worked with IPL knows, it goes well, but then the patient goes on summer vacation, and when you get this, you know you have a headache, basically. Even you or your assistant overtreats with a fractional vascular selective laser, you never have this headache, even if you cause epidermal injury, because it's a fractional injury, and it feels fine. Heals fine. So on the left side, I would have a couple of sleepless nights with a large IPL device. On the right side, hey, here's also, it heals fine, no worries. Maybe the skin gets a little bit lighter, diffusely lighter than I wanted to have, but it's all good. And then basically, for diffuse specifically, I think for diffuse redness, the 577 is a wonderful laser. Everything that's small and superficial. I have to say for for really the deep port wine stains, it's not as effective as a classical pulse dye laser. So if you have really a lot of port wine stain laser patients, you still would need probably a pulse dye laser. But for the typical patients who would like to have some remodeling, has some diffuse redness, some dyschromia, it's just perfect, basically, without any risk of sleepless nights. Also, what I'm really excited, because with regular Fraxel treatment, the treatment of melasma, we were all very excited in the past, but then with the classical 1550 Fraxel laser treatment, it really, because you have some non-responders, sometimes it gets back worse, but what Dr. Cesar is also showing, that when you treat the vascular component of a melasma, you basically starve the melasma away, and you don't get, and it appears to be, that we hopefully have right now a higher response rate and more longer-lasting response rate by not targeting the pigment within melasma, but with this vascular selective laser, fractional laser, to remove the fine vascularity that feeds the melasma. So I put a question mark because we don't know. It's still early in the game. It's, with melasma, can be still some surprise, but that would be one of the most exciting new applications, that finally we may have a gentle and long-lasting treatment by vascular selective treatment melasma. And that would be really exciting, basically. And then the combination therapies, we will see it in the next talk also. And I would like to thank you with that.